I'm going to hit record. And now we're started. So I just want to thank everyone for coming again to another one of our trauma conferences. Today, we are very privileged to have Ananth Vellimana from neurosurgery here to talk about a topic I know we're all very interested in, and there's a lot of discussion always about, no matter where our trauma patients go, and that's ICP monitoring and management in TBI. So with that, Ananth, it's your board.
All right. Thanks, Justin, for the opportunity to talk. And so, as he mentioned, I'll be talking about TBI and ICP monitoring and adjunctive management. So I have no financial conflicts of interest. So this is going to be the outline of my talk. Basically, we'll talk a little bit about epidemiology of TBI, different classification systems, how to initially manage patients with TBI, and then the concepts of cerebral blood flow, cerebral perfusion pressure, ICP, and what cerebral autoregulation is. Then we'll talk about ICP monitoring in a little bit more detail and some of the other monitoring strategies we can use, and then how we control ICP in patients, and then other considerations for TBI patients. So a simple way of looking at TBI is that it's an alteration in brain function or any other evidence of brain pathology that is caused by an external force. How common is TBI? Well, there are about 224,000 TBI-related hospitalizations in the US every year, out of which about 8% is children. And then the most common etiology for TBI among these 224,000 people is unintentional falls, which make up about half the percent of TBI. And then the other quarter is motor vehicle collisions, as you guys are all aware of. In terms of age distribution, the older you are, the higher your chances of having TBI are, especially because unintentional falls are more common in the elderly. And males are more prone to have TBI than females. Similar to TBI-related hospitalizations, there's about 60,000 annual deaths related to TBI, out of which about 4 to 5% are kids. Here, the most common etiology for TBI-related death is actually suicide, with about 35% of that population. And then again, older people are more likely to die from TBI compared to younger people, and then males are more likely to die compared to females. So what are the different ways of classifying TBI? So one way to classify TBI is just open versus closed head injury. So open means that there's penetration of the skull and there's exposure of the central nervous system to the outside world. That can occur due to gunshot wounds, which we commonly see in the St. Louis area. Some other countries, knife injuries, or other objects such as getting impaled with a rod accidentally and things like that. Closed head injury is common in MVCs, falls, etc., where there's no penetration of the skull, but there is injury to the brain parenchyma underneath it. Another way of classifying TBI is based on the severity of TBI. So that can be again subdivided into GCS, which is what we commonly use, mild being GCS of 13 to 15, moderate being GCS 9 to 12, and severe being GCS 3 to 8. In addition to that, you can classify it based on the alteration of consciousness duration, so mild meaning less than 30 minutes, moderate being 30 minutes to 6 hours, and then severe being more than 6 hours. Another way is by post-traumatic amnesia, which we typically don't use this in clinical practice, but if you're amnestic for about a day or less, then it's mild. If it's less than a week, it's moderate, and if it's more than a week, it's severe. A different way of classifying TBI is based on the structural nature of the injury. So again, you can have focal versus diffuse injury. In focal, you can have different areas of the brain that are injured. It could be sort of blood in the subarachnoid space, subdural space, epidural space, in the ventricles, in the brain tissue. Or if it's diffuse, it could just be a concussion versus a blast injury or a diffuse axonal injury. All of these sort of cause some degree of shear or rotational injury to the brain. So here's an example of a penetrating TBI due to a gunshot wound. Now this, does anybody want to type in? Otherwise, I'll just spare you the agony, but this is a subdural hematoma. This is an epidural hematoma. This is diffuse traumatic subarachnoid hemorrhage. So, this is a pretty severe form of traumatic subarachnoid hemorrhage. Typically, what we see is blood in a couple of sulci after somebody hits their head. This amount of blood, usually when we see this, it's secondary to an aneurysm rupture, but it can also occur in severe TBI. And this is an example of a focal contusion where you can see contusion in the frontal lobes here.
Hey, Ananth, you had
Yeah.
some case conference notification just pop up.
There you go.
Perfect.
Sorry. All right. Again, here you can see contusion in the frontal lobes, which is this. Right. And then this is sort of a form of diffuse axonal injury, which you can see with rotational deceleration. You can see multifocal punctate areas of microhemorrhages. So if we synthesize what we saw in the previous slides, we can classify TBI severity based on either imaging, loss of consciousness, amnesia, GCS. So typically, in our clinical practice, we use GCS the most commonly. So at the time of TBI, you have an initial injury that occurs to the brain. That obviously causes a degree of neurological deficits. Subsequent to that, you have secondary brain injury that occurs due to a variety of insults, including activation of cell death pathways, axonal structural injury, excitotoxic injury, protein accumulation, multiple other processes that happen. And this is an active area of research among different TBI scientists. We won't go into that now. So what do you do when you have a patient who in the field with a TBI? So typically you want to assess a GCS first, and then depending on that, you sort of triage them. If they have mild or moderate TBI based on the GCS and pupillary exam, then they go down one pathway, whereas if they have severe TBI, they go down another pathway. So if it's somebody who has mild TBI, that's GCS 14 or 15, you can transport them to any ED. If they have moderate TBI, which is GCS 9 to 13, you want to send them to a trauma center. And if the GCS is less than 9, you want to transport them to a trauma center that has TBI resources. Again, first priority is always maintaining your airway, your breathing, and your circulation. And then pupillary reactivity is also important. So if somebody has pupils that are asymmetric or fixed and dilated, then you want to, in addition to intubate them for airway protection, you also want to hyperventilate them till they get to a TBI management center. So again, the dictum is anybody with a GCS of less than 8, you want to intubate. So, as neurosurgeons, when we see patients with TBI, their initial injury has already occurred. Whatever damage from the initial insult that can occur to the brain has happened. So what we try to do is prevent secondary injury from downstream processes from the initial injury. So let's say if somebody has an open depressed fracture, you want to irrigate and debride the fracture and repair it. If somebody has a hematoma that is amenable to removal, you want to take it out. So if it's an epidural hematoma, or if it's a subdural hematoma that's causing significant mass effect at midline shift, you want to take those out. At the same time, if it's a diffuse injury or if it's contusions, you don't really want to resect a significant part of the brain unless you absolutely have to. So in that situation, your goal is to sort of minimize ischemia to the brain, minimize cerebral edema, and sort of support the natural healing of the brain. So in any patient with severe TBI, so we'll switch over to management of patients with severe TBI because mild TBI is not very complicated, and again, moderate TBI, typically you have a focal lesion that you remove and then they improve quickly. So for severe TBI patients, the primary goal is to maintain cerebral blood flow. So different regions of the brain have different amounts of cerebral blood flow, but globally it's more than 50 mils per 100 gram of brain tissue per minute. So unfortunately, cerebral blood flow itself is hard to measure in clinical practice. It can be done in experimental models, but not in humans that easily. So in clinical practice, we use what is called cerebral perfusion pressure, which is an approximation of your CPF. So cerebral perfusion pressure, or CPP, is basically the difference between your MAP and your intracranial pressure. So normally your CPP is more than 50 millimeters of mercury. Ideally, closer to 80 to 100 in normal people, not in TBI patients. So the concept of cerebral autoregulation is pretty important. So it basically means that the brain has a capacity to maintain your cerebral blood flow within a constant range over a wide range of cerebral perfusion. This is done by adjusting your microvascular function. And so when your CPP goes to less than 40, then your autoregulation fails and your CBF falls. So again, this sort of comes back to the concept that you want to maintain CBF in patients with TBI. So that's why autoregulation and CPP is important here. So again, just to summarize, your primary goal is to preserve cerebral blood flow. That's done by maintaining CPP, and you can maintain CPP by controlling your MAPs and by minimizing ICP. These are interventions that we can perform at the bedside. So what are the indications for monitoring ICP? So there's a Brain Trauma Foundation TBI guidelines that were published over a decade ago initially, and then they've been updated recently. The extensive guidelines were updated in 2016, and then a recent update was performed in 2020 after a randomized controlled trial of decompressive craniectomy. So I'll be referring to these guidelines for recommendations and management here on. So the first thing is these guidelines recommend ICP monitoring to reduce in-hospital and post-injury mortality in patients. So who should we monitor? So typically, anybody with severe TBI, that is GCS 3 to 8, with an abnormal CT scan. The reason we do that is because a half to a third of these patients have intracranial hypertension down the way. The other thing is if patients have severe TBI or GCS is 3 to 8, but if they have a normal CT scan, then we still do ICP monitoring if they meet two of the following criteria, which is if they're older than 40, or if they're intensive with systolics less than 90, or if they demonstrate unilateral or bilateral motor posturing. This is decerebrate or decorticate posturing. So this data comes from studies that were performed in the 1980s. So, obviously the quality of CT scanner in that day and age wasn't as good as it is now. So some of these patients who had a normal CT scan back then, nowadays you might find something abnormal. So what are the ways to measure ICP? So again, as I mentioned, it's a measure of pressure within your skull. And normally it's less than 10 to 15 in adults. So you can measure it in different ways. So typically what we use here is a bolt, which is an intraparenchymal device. Here it's shown as a subarachnoid device, but typically we use this plus a pressure sensor that actually goes into the brain parenchyma. The other way of doing it is with the external ventricular drains, which sometimes we do. Then there are also ways of monitoring it by putting an epidural electrode. We do this sometimes after a decompressive craniectomy. We leave an ICP monitor in the epidural space to monitor. But otherwise, typically, as a first line, we don't use epidural monitors. So again, this is a standard Camino monitor that you guys have all seen in various ICUs here. So when you look at ICPs, there's a distinct waveform to the ICP. So it varies with your heartbeat and also varies with your breathing. So the waveform itself has three components: the P1, or the highest peak, that's due to your arterial pulse, and the P2, nobody really knows why it happens, but it's used as a surrogate for measuring brain compliance. And P3 is your dicrotic notch from the aortic valve closure. So typically, if your brain loses its compliance, you can see that the P2 becomes prominent. In practice, we don't rely on these waveforms for interpretation as much, other than just for evaluating and making sure that the device is functioning appropriately, especially in the case of external ventricular drains that we use. So what is the preferred method of monitoring ICP. So here at WashU, we typically use a standard bolt, which is an intraparenchymal monitor to measure pressures. The American Association of Neurological Surgeons recommended method is placing a ventriculostomy on external ventricular drain. The advantage of an EVD is that it's a little bit more accurate because it doesn't have drift over time. It's reliable and also allows therapeutic drainage of CSF if you run into issues with ICP. One of the biggest downsides is that most patients with severe TBI have small ventricles to begin with. So placement of an EVD can be technically challenging. And the second issue is that it has higher incidence of complications. We rarely ever see an infection or a intraparenchymal hemorrhage related to an ICP monitor. Whereas with EVDs, we see it often. So, again, it's a better modality, but also has slightly higher risk. So in patients with subarachnoid hemorrhage, for instance, a lot of them get EVDs. Intraventricular hemorrhage or intraparenchymal hemorrhage, we put in EVDs. But for TBI, we typically try to avoid it for those reasons that I mentioned earlier. Again, the bolts that we use, one of the biggest limitations that we see is that there is drift in the actual value over time. And then sometimes, patients who've had an ICP monitor for a week or so, we have to replace the monitor because of the measurement drift. So going to the concept of CPP, again, these guidelines recommend that we monitor CPP to reduce mortality in patients with TBI. So basically, a combination of ICP plus CPP. In addition to that, there's this concept of advanced cerebral monitoring that has been used to varying degrees over the last 15 years or so. So one of the common ones is measuring brain tissue oxygenation. So the concept here is that tissue hypoxia is associated with worse outcomes. And so in centers where they do this, they insert a monitor called Lycox, which is similar to an ICP monitor, but it has the function of providing ICPs, but also you have cerebral oxygenation and temperature and things like that. So we use it a lot at children's here, but not on the adult side. Unfortunately, the guidelines itself have not made any recommendations regarding using this modality. The previous version of these guidelines from 2007 actually recommended using it, but then more recent studies came out saying that they may not be as useful, etc. So then the guidelines committee went back to saying that there's insufficient evidence to recommend using this. There is an ongoing RCT called the Boost 3, which is actually assessing either using brain tissue oxygen measurement plus ICP versus ICP monitoring alone. So I did a cerebrovascular skull-based fellowship at Seattle last year, and they were part of the Boost 3 trials, so patients would get randomized into that group. So the other thing that we can do is measuring your oxygenation content between the arterial and venous system. So this is typically done by monitoring your jugular venous oxygen concentrations. And this has also been sort of recommended in the guidelines as a weak level 3 evidence to reduce mortality and improve outcomes in the long term. Other things that people use are transcranial Dopplers, which again, there's insufficient data to support its use. And then cerebral microdialysis, which measures your brain metabolism. That's typically used in the context of research studies and very uncommonly used in clinical practice because there isn't enough data to support using that. So now, what are the thresholds that we need to look at when we use these treatment modalities? So first, as you can recall from earlier discussion, you want to maintain CPP by maintaining your MAPS and by lowering your ICP. So for blood pressure, you typically want to maintain a systolic more than 100 for patients who are 50 to 69 years old, or more than 110 for those in the younger group or the very old group. And this, according to the studies that the guidelines evaluated, has been shown to decrease mortality and improve outcomes. Similarly, ICPs, treating ICP above 22 is recommended. And then you can use a combination of ICP and clinical and brain CT findings to make management decisions. So this number of 22 is pretty interesting. We typically say 20 or 25. So this comes from a study in UK where they looked at data from about 17 years or so, and then based on statistical analysis, this is the threshold that they came up with. So that's why the guidelines, because that is the best available data, the guidelines recommended 22 based on that study. So next, what are your CPP goals that you want to use? So ideally, the recommended target is between 60 and 70. Whether 60 or 70, which of these two is better, that's unclear based on available data. And so it depends on how the patient's autoregulatory status is doing. One thing we should keep in mind is that we should avoid aggressive attempts to maintain CPP above 70 with fluids and pressors and things like that, because it can lead to respiratory failure and other complications that you don't want. In terms of advanced monitoring thresholds, so if you're measuring jugular venous oxygen saturation, then something less than 50 is what you want to avoid. And again, that is being shown to reduce mortality and improve outcomes. So what are the strategies that we can use to control ICPs? So first, simple things that we do at the bedside always is elevate the head of bed, then make sure that most patients with who come in with TBI also have a C-collar because their cervical spine hasn't been cleared. So you want to make sure that the collar is adequate but not very constrictive, because if it presses on the jugular veins, then your ICP can go up from just that. Then you can use sedation and analgesia, hyperventilation, hyperosmolar therapy, CSF drainage, pharmacological paralysis, barbiturate coma, and then decompressive craniectomy. So I'll go into all of these in a little bit of detail. So hyperventilation. So the concept here is that if you hyperventilate, you cause vasoconstriction, therefore there's decreased cerebral blood volume, and that reduces ICP. One important thing to keep in mind is that this is a temporary measure. So you can use this as a bridge to a more definitive strategy, but this alone is not sufficient. So again, the Brain Trauma Foundation guidelines do not recommend prophylactic hyperventilation. They recommend it as a temporizing measure, as we just talked about. And then ideally, if within the first 24 hours, other than for a brief period, if you want to get somebody to the OR, etc., you want to avoid hyperventilation because your CBF is already reduced. And so, vasoconstriction again reduces the CBF further. So you want to avoid it if you can. And then if you're using hyperventilation, the guidelines also recommend that you monitor either the jugular venous oxygenation or your brain tissue oxygenation. So next thing that we commonly use is hyperosmolar therapy. So the concept here is that if you create an osmotic gradient between your brain tissue and your blood vessels, then your water mobilizes from the brain to the blood, and so therefore your ICPs go down. So in terms of hyperosmolar therapy itself, you can use either hypertonic saline or mannitol. So one of the things that we look at when we're using mannitol is what the osmolar gap is. So ideally, you want a gap less than 20. A lot of people also say that you want to maintain serum osmosis less than 320. So that's a good guideline, but ultimately, your gap is what you want to be monitoring when using mannitol. And then again, sodium, you want to avoid it going above 160 if you can, because there are some studies that show that sodium greater than 160 has been associated with increased mortality. But again, each of these studies have their own limitations, and you have to interpret that in the context of what the study was meant to address. So again, we have a different kinds of agents that we use, either mannitol or varying degrees of hypertonic saline. One of the things that's not here is 5%, which we also use here. So then going to the next strategy, so CSF drainage. A lot of times, like I said, we don't have ICP or EVDs in these patients, but one thing that we can do if somebody is not responding to sedation, analgesia, hyperosmolar therapy is we can place an EVD. In some centers, they place it up front, and some centers either place an EVD up front, no ICP monitor, others do an ICP monitor on one side and EVD on the other side. Or like we do, we just place an ICP monitor and then later on we place an EVD if we have to. So the guidelines say that an EVD system that is zeroed with continuous drainage of ICP or of CSF is better than intermittent use. So the concept of intermittent use is that you have an EVD and it's clamped, you're using it to monitor ICPs, and then you sort of open it whenever you need to lower ICPs and then clamp it back again. Based on a review of several studies, the guidelines have said that it's better to do continuous drainage than use it intermittently. But then you can consider doing it intermittently in the first 12 hours or so, especially in patients with GCS less than 6. Again, these guidelines are based on certain studies. And in this particular study, they found that if you did that in patients with GCS greater than 7 or GCS 7 or more, then it's associated with worse outcomes. I don't exactly know why, but these guidelines are based on that particular study. So if all of these initial measures don't work, then the next thing that you can do is consider putting the patient in a barbiturate coma. So you don't want to do this prophylactically because it has significant side effects as well. But if you're having ICPs that are refractory to all the other measures that we talked about, including your sedation, analgesia, pharmacological paralysis, high EVD and CSF drainage, hyperosmolar etc., then ultimately this is one option. So one thing you want to make sure is that these patients have stable blood pressures before and after barbiturate therapy. The other option is, instead of doing this, go to a decompressive craniectomy. So that's going to be sort of the last main point of discussion here. So you can do two forms of decompressive craniectomy. One is decompressive hemicraniectomy. So that is you're removing bone flap on one side. So typically you do this if your injury is well lateralized to one side. So somebody has a lot of contusions on one side, less on the other, then you decompress the side with the contusion. Or somebody had an acute subdural limb that you evacuated, but they had brain edema, then you leave the bone flap out at that time. Or you put the bone flap back in and then they subsequently develop bad edema, then you go back and take the bone flap out and leave it. So those are situations when we do a unilateral decompressive craniectomy. And then the other option is to do a bilateral frontoparietal decompression. So that is a little bit more involved procedure, and you run into the issues with your superior sagittal sinus, which is in the midline, and you try to avoid it if there is a lateralizing injury to one side. So typically we use this if somebody has bifrontal, bitemporal contusions with ICPs that are refractory to medical management. So this is an example of decompressive craniectomy where you take skull off on one side and you can see how much room the brain has for expansion after that. Typically when we do this, these are the areas where we do burr holes to remove the bone flap. So what data do we have to support decompressive craniectomy? So you can think about it in ways of a primary decompressive craniectomy versus a secondary decompressive craniectomy. So we do primary decompressive craniectomy, as I mentioned earlier, sometimes in patients with acute subdural hematomas where you've taken the hematoma out and the brain is just edematous and you don't think that you can even practically place the bone flap back on. So there is a study going on which hasn't been published yet called the Rescue Acute Subdural Study, which is actually looking at this and randomizing patients to either putting the bone flap back in or leaving it out if there's clinical equipoise at that time. So the data that currently exists is for secondary decompressive craniectomy. So the first study which was published regarding this was the DECRA study, which was basically in Australia, Saudi Arabia, etc. And this was published in 2011. They had basically 155 patients who were randomized to either decompressive craniectomy or no decompressive craniectomy for ICP elevation more than 20 for 15 minutes within the first 72 hours of care. So this is basically early refractory ICP elevation. And what this study found is that there essentially patients who had a decompressive craniectomy had sort of worse outcomes compared to patients who didn't. Unfortunately, the study has several limitations, including even though it was randomized, there wasn't a true equipoise or equality between the two groups. There were a lot more patients in the decompressive craniectomy group who had pupillary lack of pupillary reactivity, etc. So most people in the field of TBI don't really ascribe a lot of importance to the study because of the limitations. Moreover, their rationale for decompressing early in a lot of patients was something that other centers would not do, because here, patients, if they had elevated ICP in the first 72 hours, even before trying any sort of first tier medical management, they went straight to decompressive craniectomy. So a lot of people disagree with that concept. So going back to the previous slide, the other study that has assessed decompressive craniectomy that was recently reported is the Rescue ICP trial. So this examined 400 plus patients, and the criteria here was that they were randomized to either decompressive craniectomy or medical management for late ICP elevation. So this is if they had ICP elevated more than 25 for 1 to 12 hours within 10 days of admission. So more of what we see in clinical practice. And in this study, what they found is that in patients who had decompressive craniectomy, they had less mortality at 6 months and 12 months, and also had favorable outcome as assessed by the Glasgow extended Glasgow outcome scale at 12 months. So based on the data from this study, the TBI guidelines were updated in 2020, and the current recommendations are that if somebody has late refractory ICP elevation, then decompressive craniectomy is recommended. Similarly, if somebody has early refractory ICP elevation, then decompressive craniectomy is not recommended. This is based on the DECRA study. If you're looking at improving mortality and favorable outcomes. But a caveat is that it is still suggested to reduce ICP and duration of ICU care, even though the effect of that on outcome is unclear. So again, it's a little controversial as to what you want to do if somebody has refractory ICP in the early phase. Then the other important thing is that when you're doing a decompressive craniectomy, either go big or go home. So you want to do a big craniectomy that's at least 15 centimeters by 12 centimeters or 15 centimeters in diameter. The thought here is that if you do a smaller craniectomy, then whatever brain is herniating out is in some ways strangulated and leads to more ischemia and injury than what you want. So studies have shown that a bigger craniectomy has improved outcomes and lesser mortality. Now, some of the other considerations in managing patients with TBI. So in the past, people have looked at using steroids, and there's level 1 evidence that steroids that methylprednisolone is associated with increased mortality, and the guidelines contraindicate the use of steroids. In terms of nutrition, since TBI leads to a high metabolic demand, you want to attain caloric replacement as quickly as possible. So ideally, you want to feed them and attain basal replacement at least by the 5th day, if not at most by the 7th day. And this has been shown to reduce mortality. The next thing is when you're feeding them, they recommend transgastric jejunal feeding to reduce the incidence of ventilator-associated pneumonia in these patients. Next is infection prophylaxis. So early tracheostomy doesn't really reduce mortality or nosocomial pneumonia, but still recommended in order to reduce the days of mechanical ventilation, as long as there are no other contraindications to doing it. Use of oral care is not recommended to reduce VAP. And then the other thing to consider to reduce infection is the use of antimicrobial EVD catheters. We typically use that for all EVDs here at this institution. And that has been shown in other diseases as well to reduce the incidence of meningitis and meningitis. The other thing that comes into question in clinical practice is DVD prophylaxis. So the guidelines say that you can use low molecular weight heparin or low dose on fraction heparin in combination with mechanical prophylaxis. However, they caution that there is a risk of expansion of intracranial hemorrhage. So typically, if somebody's had a stable hemorrhage on repeat scan, and we typically start DVD prophylaxis the next day after admission, as long as there are no other contraindications. The other thing that we commonly talk about is seizure prophylaxis. So the data for this comes from a study from a couple of decades ago, which was a randomized controlled trial, and found that the use of phenytoin decreases the incidence of early post-traumatic seizures. It does not change the incidence of late post-traumatic seizures. What is not clear is whether reduction in early post-traumatic seizures affects long-term outcome or not. But regardless, based on this data, the general practice is to use seizure prophylaxis at least for 7 days after TBI. In practice, we use Keppra compared to phenytoin. There have been studies which have shown that Keppra is equivalent, and obviously in other areas, Keppra has shown to have much less side effects compared to phenytoin. In the context of these guidelines, there isn't enough data for them to provide a level of evidence. So they've basically said that there is insufficient evidence to recommend using it compared to phenytoin. Right. So I know this was kind of a quick whirlwind tour of TBI. So open to any questions.
Well, thank you very much for that, Ananth. I know it's one of these, I know for most of us, and I see it in trauma, I see it in the ICU, it's kind of this black box that we're always just trying to get a better understanding of why things are done the way they are. I think there were 2 points that you hit home, or the 2 issues that I often hear. One is who gets the bolt, and you kind of address that. I guess one that goes with that is bolt versus EVD, and you explained definitely why EVD is more accurate, but has its risks. The other thing that I know comes up in the ICU all the time is ICP versus CPP.
Right. And
we definitely hear from, I won't say pushback, but definitely from the neurosurgical side, when we're working in the ICU, we hear, we follow the CPPs very closely, and there's definitely some pushback as to focusing more on the ICPs. I don't know if this is like personal preference, or if there's something to that, or if you have any comment on that specifically.
Yeah, so I think, in terms of monitoring just ICPs versus ICP plus CPP, at least the guidelines say that you should be using both. I think in practice, sort of these are all things that have evolved over the last last decade or so, and I think most people are comfortable managing ICPs alone, because the thought is that nobody is really hypotensive, so as long as they're normotensive, then if you reduce ICPs, your CPP would be more than 60 or more than 70. But again, I think part of it is also individual preference. So if you ask me whether I'd be how I would want to manage, I'd probably want to do it, or not probably, I would want to do a combination of both, making sure that their ICPs are controlled, but at the same time, having a CPP goal more than 60, and not just, standard CPP of 50, which used to be kind of the traditional practice. So again, in a nutshell, I think it's basically an individual surgeon preference, really, and institutional preference too.
Do you think the neuro exam matters at all to that?
Yeah, so, right. So I think, again, for that, there are 2 ways of looking at it. If somebody has an ICP monitor in place, then it probably doesn't, because then, you're going by the ICP numbers. And then if the ICPs have been normal, then you want to wean sedation, get an exam. If they follow commands, then you want to take the ICP monitor out, because they don't really need the ICP monitor anymore, because then once somebody starts following commands, their GCS typically is more than 8, right? So they don't have indications for that anymore. In terms of so there was a randomized controlled trial that was done and published in NEJM in 2012. This was done in South America, where they actually had low resource setting, and so looked at one strategy of just clinical management using neurological exam and CT scan findings versus using ICP monitor. And the study conclusion was that ICP monitoring didn't really change outcomes. But again, one of the caveats is that this was done in countries where patients don't have access to good quality healthcare like we do in the US. So a lot of times patients with severe TBI didn't even get to a hospital within for up to like 2 or 3 hours after the initial injury. Second is that in general, these countries have 2 to 3 highfold higher mortality in TBI patients compared to the US. So you can't really apply that to the US, but people in other parts of the world do manage them based on clinical exam and CT findings and sort of empiric therapy compared to here. So I think, to answer your question, if somebody's had normal ICPs, then the exam matters so that you can get the ICP monitor out. In somebody who has sustained elevation of ICPs, you want to control the ICPs, so you want to keep them sedated, and there the exam doesn't really matter as much.
Well, thank you for that. There's a question in the chat from Dr. Chang who wanted to know if you had any comments on the best trip study.
Best trip, I'm not totally sure about the details of the study. Which one was that? If you just type it, I might know based on what the contents are, but I just don't remember the name and what the exact details of this are.
Oh, I think you just covered it. All right.
Oh.
So
that is the best trip was the NEJM study where they looked at ICP monitoring versus clinical exam, right? I think that was it. I just didn't remember the name of that.
Well, good. We're on the same page with that. Yeah. Anyone else have any questions, any comments that they want to present? Well, good. I have more questions then. I guess I'm curious where you think the field is going. So you brought up some advanced monitoring techniques.
Right.
Do you see, like, we don't use those here,
right?
Or at least I don't see that in the SICU.
Yeah, we do use Lycox in kids. We've been using it since the time I was a junior resident. So probably like 10 years now.
What do you see the field doing in the next 5 to 10 years? Where do you see this going?
Yeah, so I think in terms of monitoring, I think the field is going towards doing more invasive and more sort of detailed measurement of brain metabolism in these patients. So I think the Boost 3 study that is going to show, or based on the findings of that, I think either brain tissue oxygenation may take on, or other methods to assess brain metabolism, because I think one of the biggest issues that we face is that just ICP doesn't give you an idea of what the tissue status is, what is the metabolism at the tissue level. So I think that and people are using microdialysis for research purposes. So I think at some point, it's a complicated thing to do. So at some point there may be a surrogate that is developed for that people end up using to assess brain metabolism per se, rather than just numbers of ICPs. So I think that's where the field is going. And the other thing is, TBI, depending on the kind of etiology, there's a big difference in what the outcome is. Somebody who has bifrontal contusions is going to do very differently from somebody who has DAI, right? So then understanding the pathophysiology of different processes like that, that's also going to ultimately change the way we manage these diseases too.
Yeah, I guess that's something we definitely see in the ICU is the nuances between each type of injury and how much invasive monitoring we're really doing for it, and right, what we think the outcome is going to be.
Yeah, and some for patients who have DAI, for instance, and don't have discrete lesions that you can see to cause mass effect, a lot of people are hesitant to even do decompressive craniectomies for these patients because it's sort of a diffuse injury that at least their argument is that decompression doesn't really help their prognosis, because the etiology for their poor exam is not ICPs, it is the sheer injury that they sustained to begin with.
Sure. There's another question in the chat. Any thoughts on a cisternostomy
People are using that in Asia a lot. And I've spoken to a few people who've done that, and they seem to suggest that it really works, and you can avoid, even leaving the bone flap out in those patients. Nobody in, Europe and US has really taken that on for a couple of reasons. One is that, if you want to, in patients with TBI, typically they have a lot of cerebral edema. So just going and doing a cystonostomy, you're sort of, applying unnecessary force on an injured brain, trying to retract it and things like that. So, it can be done, but typically, in other situations, for instance, somebody has a subarachnoid hemorrhage. One of the things that when you operate on them for an aneurysm clipping, you worry about is having a retraction-related injury and things like that. So the things that you're trying to avoid here, you may end up getting that just trying to open up the cisterns. But the concept here again is that, people who are proponents of this argue that your ventricles and your subarachnoid space and all that, they're not in true communication, and so if you open up the cisterns, you get more brain relaxation and all that. So I've never done it in this context in TBI, but when you go in for other purposes and you do it, yeah, definitely the brain relaxes. But then again, a couple of days later, the brain expands, or everything expands and comes back to a normal size once all that CSF reaccumulates. So I don't really know what it is, but people who are using it seem to like it.
I don't know if Dr. Cheng wants to comment at all about that. I'll leave it open for a sec. Any other questions, comments, anything people want to bring up? I'm not seeing anything come, so.
I'm sorry, was that a question to me?
If you want, I was just curious if, since you brought it up in terms of the cystonostomy, you want to comment.
Yeah, so, one of those speakers, his name is Ip Cherian. He was based out of Nepal. He made his name in Nepal, but he wrote most of these papers, and I ran into him at a neurosurgery conference, out of the United States some years ago. So, and obviously he's been talking about it, writing papers and showing pictures, etc. So I was just curious in terms of at an American tertiary care hospital, what the thoughts are, because I know we're not doing it in North America, but I was just curious in terms of maybe there are pockets of patients where in combination with, cranial skull-based techniques, that there would be some role for that, or if you were trying it on some patients, because I've not had any experience with it. I've just heard about it from this one doctor that I know personally, who kind of is the thought leader, supposedly in this area right now. So.
Yeah, no, I've there's a neurosurgery group on Facebook, and I've chatted with Ip Cherian about cystonostomy, and he puts forward logical arguments. At some point I do want to try it, but I just never done it because it adds a different level of complexity to decompression that you're doing. You bring in the operating microscope, like I said, you're going to retract a brain that's already edematous and all that. And, the way he talks about it, you go a lot more than just opening up cisterns in the anterior skull base. They talk about peeling off the cavernous sinus and opening up cisterns near the midbrain and all that. And I think that is very involved. Even in elective patients, when you're doing things like that, it's associated with cranial neuropathies and morbidity. So, I think taking it to that extreme may not be necessary, but if you just want to go in and open up your, prechiasmatic cistern and optical carotid cisterns and things like that, and fenestrate the lamina terminalis, I think that is sort of, a simple, relatively simple way of doing it may be beneficial.
Thank you.
And I just want to say, Dr. Cheng, thank you for joining us. I know you're at Carbondale, and welcome to the conference, and please feel
Thank
free.
you.
I know Kelly gave you the invite. We're happy to have you here, so thank you very much.
Thank you so much.
That sounds like a great topic for a future talk, by the way. That's exactly what we would love to hear about. So something a little bit out there, and but definitely advanced. Any other comments? Anyone else have any questions? All right. Well, with that, Ananth, thank you very much for sharing with us. That was great and actually really helpful to get that insight as to where you guys are coming from a lot of times with the neurosurgery approach. If you guys have any ideas for other conferences, I'm definitely looking to fill the rest of the year. I think you're going to have to listen to me talk next month, and I get to talk about whatever I want. So I think it's going to be albumin and trauma. And that's the punishment for no one volunteering. So, and then I'll try and fill up the rest of the year. But yeah, if anyone has any topics, anything of interest that they want to bring up or have ideas, please let me know. I tried to take attendance, and so we are submitting this all for CME. And with that, thank you very much, and I'll see you guys next month.
Thanks, Justin. Thank you, guys. Have a good evening.